Okay. What I'd like to do now is I'd like to introduce to you Dr. Scott Collins. Dr. Collins is an associate professor, and he's the director of the Duke ADHD program in the Department of Psychiatry. And Dr. Collins has conducted research in ADHD and stimulant psychopharmacology for the past 15 years. Dr. Collins is going to give you a little bit of a background of what they do at the ADHD clinic.
Okay. Thanks. Good afternoon. Appreciate y'all having me. Are my slides hot now? I can just... I did. All right. Well, I can talk about what our... just to give you a little bit of an overview and get everybody settled in here. We have a specialty clinic for ADHD, attention deficit hyperactivity disorder. It sits over on Rutherford Street behind the Wachovia building. And what we do over there, a range of activities, but everything that focuses on ADHD. We have a pretty bustling outpatient clinic, so we see kids, we see adolescents, we see adults. Of course, as part of the university, our primary mission is research. That's what keeps our lights on. More than anything, we have a wide range of federally funded research from molecular genetic studies. We've got a pretty active human psychopharmacology laboratory where we do a range of studies. And then we also do clinical trials and other longitudinal studies. We're also pretty actively involved in industry-funded trials. It's in the last 10 years or so, it's been a very hot area. Industry is been working very hard to develop a number of new pharmacological treatments. And we've been fortunate to participate in a lot of those. So just to give you a little bit of a background about what we do, I am a clinical psychologist by training, but starting in graduate school, started doing work with psychopharmacology, behavioral pharmacology, really trying to understand how the drugs that we use to treat ADHD work. Increasingly over the years, I've gotten interested in the intersection between ADHD and substance abuse. People who have ADHD are at increased risk for having problems with a whole range of substances. What our research is focusing on is smoking. There's, as many of y'all probably know, there's a lot of very good smoking and nicotine researchers here at Duke, and we've teamed up and are really trying to tackle that question. So I'm happy to answer questions towards the end. Obviously, if we might not have time for everybody to have their questions answered, shoot me an email. I'm in the system. I'm the only Collins with a K. So just in terms of what I want to talk about today, I want to get us all centered on the same page. There's a lot of, as I'll talk about later, there's a lot of misconceptions, a lot of misunderstandings about what is ADHD. So I want to start from the clinical side and talk about, first of all, go through the diagnostic criteria for the disorder, as well as talking a little bit about what this disorder looks like across the lifespan, from preschool age through adulthood. Then I want to organize, and actually I confess that you guys are guinea pigs to some extent. I've given a lot of these kinds of just general overview talks, and I finally realized that a good way to organize the information is around myths and misconceptions. So this is a new order and a new way of putting things together, but I think it'll be informative because there's lots and lots of misinformation out there about ADHD. I've kind of, thinking back over my experience, talking with parents, talking to people out in the community, tried to highlight some of the most common myths and misconceptions, and I'm going to address those with what we know from the research literature. In fact, one of the things that we specifically tell our patients and people that come through our clinic not to do is to go and Google ADHD, because 95% of the information that you're going to get is not substantiated. It's sometimes terrifying and usually patently false. So hopefully I can address some of these myths and misconceptions. But first, it's really important to make sure that we're on the same page. These are the 5 criteria that are used from the DSM-4, which is our psychiatric manual for diagnosing all mental health illnesses. These are the 5 criteria that are used to diagnose ADHD. And I want to walk through fairly briefly, but I can't underscore enough the importance of really focusing on these criteria to make a diagnosis. In fact, I'll steal a little bit of my thunder from later on, but one of the biggest problems that we see, and this has been documented in various ways in the research, is that there's too often less attention paid to these diagnostic criteria, and so there's a lot of kids out there that end up getting assigned a diagnosis of ADHD because a thorough evaluation that adheres to these criteria has not been conducted. So, first of all, are the first criterion has to do with the symptoms of ADHD. I haven't listed them up here again because I want to be brief about this, but suffice it to say that there are two general clusters of symptoms. There are inattentive symptoms and there are hyperactive impulsive symptoms. And in order to meet this first criterion, a person has got to exhibit a specific number of these symptoms from one or both of these lists. And when we say they have to exhibit the symptoms, just like any other psychiatric or medical or many other medical disorders for that matter, if you look through the symptoms, and this is where a lot of problems come in, people go, oh my God, I've got ADHD. Because, yeah, I lose things, and from time to time I can't pay attention and things like that. So that's why it's important to have a clinical assessment for somebody to look at this and say, okay, for the typical 8-year-old female, sure, there's a base rate of that in the general population, but what is clinically significant or what's developmentally inappropriate? So that's the first criterion. The second criterion, and actually, a lot of times this is where the assessment stops. For a variety of reasons, parent has problems with the kid, they go to their primary care provider. Primary care provider gives a checklist or a symptom checklist. Parents fill it out. Pediatrician says, okay, this is ADHD, and they leave with some medication. That leads to all sorts of other problems and issues. Now again, and it's important to emphasize that that is not the pediatrician or primary care provider's fault per se. It has to do with resources and what the time that they have available to actually do a good evaluation, what the resources that they might have available to make a referral to somebody else, etc. But that is oftentimes the root of the problem, is that a full assessment that includes all of these criteria is not conducted. So the second criterion is that it has to we have to have evidence for the onset of the disorder early in life. Now in the DSM it actually says age 7. That's all of us in the field recognize that that's an arbitrary cutoff, and the spirit of it is that this is not a disorder that just emerges in middle school, junior high, high school, or adulthood. This is something that is present from early on, and I'll talk to you in a little bit about how that ties in with our conceptualization of the disorder as a genetically caused disorder that has clear neurobiological basis. So it makes sense that a person is born with a predisposition to have ADHD. It's going to start manifesting itself pretty early. So we want to get at that. This is a real challenge when we start assessing older people, older being anybody from adolescence on up. Oftentimes, especially in our adult patients, they don't remember what they did last week, let alone asking them, how were you in kindergarten? So we have to rely on a number of good clinical interviewing methods to be able to get some of this information about the chronicity of the disorder. Third thing is we have to focus on pervasiveness. And again, this goes back to the idea this is not something that's turned on or off when a kid is in school or out of school, or when an adult is at work or home from work. This is a pervasive problem, and it cuts across settings. So we're looking for the symptoms to manifest themselves across a range of settings. If we get a case in and the parent says, the teacher is complaining every single day about problems in the classroom, this, that, or the other behavior that sounds like ADHD, but we don't see it at home, we don't see it in church, we don't see it on soccer practice, we're immediately thinking, okay, what else is going on here? Is there a learning problem? Is there something about the school environment that might be contributing to these behaviors? But if it's not pervasive, it's likely not to be ADHD. Fourth thing, it has to cause impairment. Now, in our setting, we're a specialty clinic. This is easy because usually by the time they get to us, it's clear that they're having problems. In primary care settings, this is a lot more challenging, is to be able to figure out, all right, are these symptoms really causing problems for this person in their day-to-day functioning across a range of domains, in school, in social activities, at home, in their sort of personal domain of functioning. So we have to be careful to assess that and make sure that we can document impairment. Because again, it's certainly possible for people to have high levels of symptoms that it doesn't impact their life on a day-to-day basis. That person doesn't meet the criteria for ADHD. Fifth thing, probably the most challenging across clinical settings, is making sure that the symptoms we see aren't better accounted for by something else. wide range of psychiatric disorders that can look like ADHD. Bipolar disorder, major depressive disorder, anxiety disorder, substance use disorders. All of these, if you look through the symptoms, have things that look very similar to the symptoms for ADHD. So we have to do a very good differential diagnosis. And what complicates it actually is the fact that individuals with ADHD are actually at increased risk for all of those things that I just mentioned. So it's possible that they could both be there, both of the disorders, and figuring out where an anxiety disorder ends and where ADHD starts is a clinical challenge. And we've got to, there's no good way of doing that other than doing good clinical interviewing. And I'll come back to that point a little bit later. So these are the criteria for ADHD. What does this look like? Well, one of the challenges that we face is that ADHD is a lifelong disorder, and it is persistent, but it looks different across different age ranges. So I want to walk through and just talk a little bit about sort of the different manifestations of this in different ages. First of all, in the preschool age range, we have a lot of experience working with preschool kids. We've done a couple of big NIH-funded studies focusing on preschoolers. And this is when you first start to see the symptoms. In fact, I could present some other sort of anecdotal clinical data about onset of symptoms even before the preschool years. I've had a number of patients come in. Moms say, they have an older brother or sister, and mom says, I knew something was different when I was pregnant with this child. So even seriously, and in terms of activity level or just not getting on the same sort of consistent cycles of activity and non-activity, they've noticed differences. But by the preschool years, usually you're going to start to see these symptoms manifest themselves. Usually what you see is more of the hyperactive impulsive symptoms, mainly because most times preschoolers aren't really challenged to sit down, focus for any period of time. So what we see is the real impulsiveness, running around, sometimes really having difficulty with non-compliance, playing a lot more loudly and a lot more vigorously than their peers. I didn't think it was possible until we started doing some work with this NIMH study. I didn't think it was possible to get expelled from preschool, but you can get expelled from preschool. Just when we had a number of kids that preschools just said, we just can't have this child in here anymore because they are too disruptive, and not in an aggressive way, but just they constantly have to be monitored, and these places don't have the resources for that. Moving through the age range, by the time you get to the elementary, middle school, this is the kind of bread and butter ADHD case. This is what most people are kind of familiar with. This is the modal age that we get referrals into our clinic. This is when the kids get into school, and I'll tell you the most common age, or really it's the most common grade around here at least, third grade. Kids get to third grade because for the first time in third grade, what happens? What's that? Well, letter grades, what else in terms of the structure? No naps. Kids start changing classes. They have more than one teacher. And that transition time can really, it's not the same everywhere, but in general, that is third grade is when you start to have, you might only have two different teachers. Some schools around here you have more, but that usually happens in third grade, and that's when the wheels fall off. The transitions, the moving from one setting to another can be a real problem. Start to see the academic problems manifest themselves. The impulsive symptoms, the hyperactive impulsive symptoms continue to be there like they were from preschool, but now you've got the inattentive symptoms in the classroom setting added on to that. Moving on up into adolescence, start to see, adolescence by itself is a challenging time, and adding ADHD on top of that only exacerbates it. One of probably the biggest thing that we worry about with our adolescent patients is how that impulsivity is going to manifest itself. It's well worked out, and there's actually a neurobiological basis for this, that even typical adolescence is a time when humans and most other species are going to engage in more impulsive, more risky kinds of behaviors. ADHD, by definition, has higher than normal levels of that behavior, or those kinds of behaviors. So this is a real problem when we start to see kids driving. When they first have the opportunity to experiment with drugs and alcohol, they start to engage in risky sexual behavior. So all of these things sort of compound. Usually by adolescence also, you start to see some kind of carryover effects. So kids in middle school, because of their ADHD, start to struggle a little bit with school. And this is irrespective of how smart they are. ADHD doesn't discriminate across IQ range. So you can be 180 IQ and still have very, very, very bad ADHD. So kids in elementary, middle school start to struggle with grades. What happens when they start to struggle with grades? Well, they sort of fall into a social hierarchy in school. They start getting frustrated. That might lead them to start hanging out with sort of the wrong kids. And what happens when they get to adolescence and they're hanging out with those wrong kids? You see all sorts of social problems start to develop. I mean, they're developing early, but you really start to see them exacerbated during adolescence. So moving into adulthood, and I'll talk a little bit more, towards the in the middle of the presentation about adult ADHD, because it's a fairly, compared to the history of the disorder as a whole, our recognition and understanding of the disorder as it persists into adulthood is relatively new. Last 20 years or so, an enormous amount of work's been done to characterize that. What it looks like in adulthood: disorganization, failing to follow through on things. I typically see when I look through the chart before I see one of our adult patients, look at the job history, and they've had 20 different jobs in the last 6 years. They have problem relationships, and again, I'll go into some of this in a little bit more detail later. Oftentimes, and especially being as part of a university community, we see sort of an unusual segment of people, and that is very, very high-functioning adults with ADHD. So we get faculty members, we get graduate and professional students who are extraordinarily bright. And again, that's when you start to run into the challenge of identifying and defining impairment. But it's there. You see the faculty member who has struggled, in spite of being brilliant, they've struggled to meet the demands of their professional career, and they've risen up to a point that they've finally hit a wall, and they can't get the papers done, or they can't get the grants done in order to move up to get promoted, etc. One of my favorite anecdotes for an adult case is a woman I saw 8 or 9 years ago. She was actually, she had gotten to be the chief resident of a very, very challenging specialty here at Duke, actually a male-dominated specialty as well, so she was extremely bright. And as soon as she took over that role, everything sort of fell apart. Start to go through her history. Through undergraduate, her mom, she made a 4.0 in undergrad, but her mom came every single weekend to her campus, organized her week, here's what you're going to do. Graduate or medical school, she had a significant other that pretty much did the same thing for her. She was able to get through the first few years of residency, and now she was chief resident, and it was too much responsibility. She was conscientious enough to know, gosh, I got to get all this dictation done, I've got to get these other things done, but it took her 2 to 3 times as long to get it finished as the rest of her peers, and so she was completely overwhelmed. She had a little girl. She had I remember the most one of the saddest but most impairing examples of one of her symptoms, which was forgetting things. She had forgotten her little girl's birthday 2 years in a row, because she was so busy and overwhelmed with work stuff. So, this is how this presents. That also reminds me, another thing that we often see with our adults, which again speaks to the issue of making a good differential diagnosis, is mood problems or anxiety problems that are completely secondary to ADHD. So this particular case, this woman she didn't meet the criteria for major depression, but she was a wreck, and she was very down on herself, and she had a mood problem that was secondary to all this other stuff that was going on. A lot of times we see similar things with anxiety problems. We have our patients fill out or complete a computer-based interview that screens for a range of other psychiatric disorders. And one of the more common ones that we see positive on the screen is obsessive-compulsive disorder, which is, and I've gotten to the point now, I see that and I usually know what that means. What it is that these folks, and especially higher functioning, very conscientious patients, know that they have problems or know that they have these deficits in areas, and so they overcompensate by developing these really weird patterns or rituals things so that they don't forget something or so that they finish a task in a timely manner. And so when the stock questions come up for obsessive compulsive disorder, they answer yes to it. They don't have obsessive compulsive disorder, but they have these really maladaptive ways of dealing with things to compensate for their disorder. So that's what it looks like in adulthood. And again, I could spend the rest of the time talking about this, but in the interest of making sure that we have a time for a little bit of discussion at the end, I'm going to move on and start to focus on some of these myths and misconceptions. Well, one of the biggest and probably the most common question that comes up if I meet somebody and tell them what I do, they say, "Oh, well, isn't ADHD, isn't it just really increased in prevalence just in the last 10 years? Or isn't it overdiagnosed? Or aren't we over-treating our kids or over-medicating them?" Well, those are all reasonable questions, and you could get that perception just by reading the papers, watching news programs, etc. But in fact, that's not the case. So indulge me for a second. I want to share a couple of poems with you. The first one is titled "Johnny Head in Air," and I'm not going to read through this, but you can take a look at it. But it's about a little boy who used to walk along to school. He never paid attention to what he was doing, and one day he was walking along. Oops. Oh no. And he tripped over a dog because he's walking around looking up with his head in the air. The second poem is about Fidgety Phil. And poor Fidgety Phil sits at the dinner table and he can't stop rocking back in his chair and call it being a little bit disruptive, and his parents plead with him, "Can't you be a little gentleman?" Until finally one day he leans too far back in his chair and messes up the whole table and upsets dinner. Now you can probably tell just from the nature of the language and the illustrations, these weren't published recently. These were actually published in a medical journal in the 1860s. And if you look at these descriptions, Johnny Head in Air and Fidgety Phil, they are pretty good descriptions even today of what we would think about as inattentive type or hyperactive impulsive type ADHD. So it's clear that this is something that's been recognized for many, many, many years. This is a timeline, and it's actually a truncated timeline of the history of the diagnosis. It's gone through a number of different name changes, but actually if you go all the way back, the first time it was kind of formally recognized was in 1902. There's an article published in The Lancet by a guy named George Still. It was called Still's disease at the time. But if you read that description, it's very, very similar to what we see today, which again, I want to bring you back to the idea, we think about this as a genetically caused neurobiological disorder. So if we see it now, if it's in our genome, then sure, it was there 150, 200, maybe beyond. There's actually a lot of interesting work to try to figure out how ADHD was actually selected for in the genes going back hundreds or thousands of years. What is it about this pattern of behaviors that might have at one time been adaptive, and why is it stuck around? That's another sort of interesting philosophical discussion. But as you can see here, it's changed names a lot, but even going all the way back to the early days, the pattern of behaviors that sort of characterize this disorder have remained remarkably similar. So no, it is not something that's just brand new, and it's not a fad diagnosis. Now, it is certainly true that, that the recognition of the disorder has increased, and that's increased in the last 15 to 20 years, in large part due to the lots of controversies, which I'll talk about in a little bit, regarding stimulant medication treatment for ADHD. Let's see. Like I said, because I put these slides together, I don't remember exactly what's coming next. There we go. So this is just to highlight the prevalence of ADHD in the U.S. Somewhere, the best estimates are somewhere between about 6 and 8% of kids meet criteria for ADHD. Only about half of them are treated. More recent data, again, now that we're starting to acknowledge, yes, this does persist into adulthood, about 4 to 5% of adults are diagnosed with, or meet the criteria, I should say, for ADHD. They might not be diagnosed. Only about 10% of adults who meet the criteria for ADHD are currently treated. Now, this is consistent with a lot of other studies that have been conducted following people through the lifespan, showing that about 50 to 60% of individuals who meet the criteria as kids are going to continue to have problems with adults. Now, ADHD, maybe this is just something in our fast-paced U.S. society that is that we hear a lot about this. Well, there's been work that's been done showing that the prevalence rate really doesn't differ no matter where you look across the world. Lots and lots of prevalence studies have been conducted. In just about every corner of the world, and there's remarkable convergence in terms of the prevalence rates. There's some differences, but if you look at specific comparisons between geographical regions, between Africa and the Middle East, compare it to North America, which is the U.S. and Canada, of course, there are some differences there, but that's probably because the number of studies and the variability of the studies conducted in the Middle East and Africa is very small. That's the sort of Pacific Rim area, Australia, New Zealand. So, this is not something that's just a U.S. phenomenon. And again, increasingly, there's more and more work being done outside of the U.S. on the disorder. Number of investigators throughout Europe have studied this for years and years. China is actually, there's a lot of work being done in China now, kind of characterizing the disorder in young folks there. I want to say one more thing about this before I move on to the next myth. I mentioned the notion and this kind of perception that people have that this is overdiagnosed or that we're over-medicating kids. That's not necessarily true, and actually what's happening is that we are misdiagnosing and mistreating our kids. And the way that works is as follows, and this was best illustrated by some work that colleagues here at Duke have done, Adrian Angold and Jane Costello, who did a large epidemiological study in the western part of North Carolina. It's called the Great Smoky Mountain Study. And they followed this big study of mental health across all sorts of aspects of mental health in children. And they sampled pretty much every kid in, I can't remember how many counties they looked in, but they had several thousand kids. And so they wanted to kind of characterize what are the real base rates in the population of ADHD. And what they found was a base rate of somewhere between 4 and 5%, which is a little lower than what I showed you before, but it's within a margin of error. So they found about 4 to 5% of the kids, drawn. Now these weren't kids necessarily who had previously been diagnosed. They were just, since they were sampling everybody and evaluating them carefully, you could get a base rate for the disorder in the population. Then they also asked questions about who was getting treated with medication for ADHD. And what they found, similar proportion, about 4 to 5% of kids were being treated for ADHD. The problem was that this 4 to 5% of kids and this 4 to 5% of kids were not necessarily the exact same kids. Now, there was overlap for sure, but there were a lot of kids who met the criteria for the disorder who weren't getting any treatment. There were a lot of kids over here who were getting treated for ADHD, but who didn't meet the criteria. They had other kinds of problems, and again, that sort of fuels this perception in the public that it's these kids over here who are getting treated for ADHD when in fact they need other kinds of treatment. That's where we get this perception, well, medication just doesn't work, and why should I give it to my kid? Well, that's because you hear stories and you talk to your neighbor about kids getting treated and they actually have oppositional defiant disorder or depression or some kind of anxiety disorder, and they're being treated for ADHD. It's not going to cure or solve the problems. So that's something important to keep in mind. And this other group of kids out here, there's a lot of kids, and there are a lot of problems with kids who really do meet the criteria for ADHD being underserved and not getting the treatment that they need. So that's, a lot of people involved in sort of services research are working hard to try to figure out ways to address that. Okay. So next myth, this is not really a disorder. It's just bad parenting or spirited kids or boys just being boys. It's another myth or misconception that you commonly see. So what I want to do to kind of address this myth is walk you through the evidence, and I've mentioned it several times, that this is a true disorder. It's in our genes, and it has a very clear neurobiological basis. So first of all, just to kind of highlight some of the adverse consequences of having ADHD. People who are defined in studies as having ADHD compared to those that don't are at risk for a whole host of problems. Lower academic achievement, higher divorce rate, lower occupational and vocational success, increased risk for other kinds of psychiatric problems, more likely to get in trouble with the law, be arrested, incarcerated, more accidents and visits to the ER, more driving problems, speeding tickets, motor vehicle accidents. Actually, there's a really interesting study that was done 7 or 8 years ago looking at the risk for having your first driving accident when you turn 16 in ADHD and non-ADHD adolescents. Do you think that the ADHD adolescents were at higher risk for having that first accident? It's a trick question. No, they weren't. For having their first accident. The story there is that all adolescents are bad drivers. So if you look at the risk for having the first accident, they were roughly the same. If you look at the risk for having the second, third, fourth on up, ADHD kids got or were at much higher risk. So they don't learn from that first accident the same way that their non-ADHD peers do. But in any case, the point I want to make here is that this has real significant consequences. This is not just boys being boys. This is not just parents who aren't managing their kids well. Now, there's absolutely a component of parenting that contributes to how badly or how impairing the ADHD is going to be. I don't want to minimize that aspect, and I also don't want to suggest that, well, if a child has ADHD, that it makes no difference what's going on in the home environment, because it absolutely does. But you cannot attribute all of the behaviors and problems we see in ADHD just to those kinds of outcomes. This is just a figure of the effects of the impact of ADHD on society in terms of costs, doing just kind of economic analysis. Very, very conservative estimates put the cost somewhere around $40 billion a year, up to as high as $120 billion. Just by comparison, some of our... What's that? These costs are lost productivity from parents or burden on the healthcare system in terms of costs for medication and ER visits or driving accidents. So the studies vary a little bit different, but there is some consistent approach, some overall consistent approach in terms of how to how to define the cost of an illness. But these costs of illness are comparable to many other, certainly psychiatric and other kinds of medical conditions as well. So ADHD leads to negative outcomes. It causes significant, or poses a significant burden on society. Moving on a little bit, it's also one of the most heritable of all of our psychiatric disorders in terms of how likely it is that it's going to run in families. Every single method that we have for studying the genetics of a disorder converge on the idea that this is a genetically based disorder. Family studies. So just looking, if you have a child with ADHD and you're a parent, you are at significantly increased risk. If you're the sibling of a kid with ADHD, you're at increased risk for having the disorder compared to siblings who don't have a brother or sister with ADHD. Those are family studies. Twin studies. We look at the likelihood of a twin having the disorder if their other twin has it as well, and we look at that in both identical and non-identical twins to come up. That's one way that we calculate heritability estimates. And the concordance rate, or the likelihood that identical twins are both going to have it, significantly greater than in monozygotic twins. Adoption studies. Many of these are a little bit older. They're done in other countries, but still, the likelihood of children who have been adopted at an early age and go to a completely separate environment, the likelihood of a kid having ADHD if one of their biological parents has it is much higher than the likelihood of them having it if one of their adoptive parents has it. So again, all of these are different methods for studying, is this genetic in nature? And we've also, and I'll talk about this briefly in a moment, in the last 10 years, one of the, kind of, as with other psychiatric disorders, one of the biggest areas of research has been on the molecular genetics of ADHD. We've known for a number of years that based on these family studies, twin studies, adoption studies, yeah, it runs in families. Now we're trying to figure out what genes are involved with that. We don't have any dramatic success yet, but we're definitely making progress. This is just to show you the convergence across studies, 20 different twin studies, and these heritability estimates, which basically, you can think of a heritability estimate as the relative contribution of genes versus environmental factors. So 1 means it's 100% heritable. You know, your eye color, for example, is 100% heritable. So when you look across studies and you get heritability estimates that usually end up converging around 0.7, 0.8, that's very high. Bipolar disorder and schizophrenia are the only other 2 psychiatric disorders that are even in that range. The rest of them are lower. These heritability estimates are similar to what we would see for something like height or IQ. So very, very strongly heritable. Why would there be that's a good question. Why would there? Well, so the question is, why would there be a difference in gender if there is if it's so heritable? I'm not sure that it necessarily has to be. I mean, actually, one thing to say about gender differences first is that the gender differences that we see in the population are much closer than what we see in clinic-referred samples. So what you oftentimes hear is that 3 to 5 times as many boys have ADHD as girls. That's if you look in our clinic. We get more referrals from boys than girls. If you look in those population-based studies, it's more like 2 to 1. And if you actually look at persistence into adulthood, it ends up being more like 1 to 1. So the first point is that there's not as great a gender difference as you think. And I don't think, I mean, I'd have to think about that question a little bit more, but I don't think necessarily that the fact that it's highly heritable would have a huge effect on whether or not it's sort of differentially prevalent in boys versus girls or males versus females. Yep. That could be. I'm not sure about exactly what those numbers are, but that's a possibility. Did I see one other hand? Okay. Oh, yeah? Okay. This is just, again, like I said, I want to mention this briefly. These are some specific genes that have been implicated potentially in the development of ADHD. For those of you guys that are interested in this, all 4 of these genes are involved with dopamine neurotransmission, which is a key player in ADHD. Again, I could talk for a long time about dopamine and how it's involved and how it might be involved in other comorbidities, but in the interest of time, I'm going to kind of move quickly. A couple of other genes that are associated in serotonin neurotransmission, and this is kind of another gene that's involved in sort of regulating both dopamine, serotonin, as well as some other neurotransmitters. But the take-home message here is that there is some convergent, and each of these genes has been replicated in at least 3 studies. This is a meta-analysis that was conducted. So each of these has been replicated in at least 3 studies. There are probably 100 other genes that have been reported on in the literature, but that we haven't had convergent evidence. So these seem to be consistently associated with ADHD, but then the other thing I call your attention to is that this is the odds ratio of 1 is kind of your where you draw the line for something being significant. So these things are not really individually, none of these genes by itself confers all that much risk for getting the disorder. Another way to think about that is, let's take this DRD4 gene, which is probably the most widely replicated gene associated with ADHD. A particular variant of that gene occurs with greater frequency in individuals with ADHD compared to those who don't have it. But there are lots and lots and lots of people who don't have ADHD who have that gene variant. There are lots of people with ADHD who don't have that gene variant. So this doesn't help us clinically at all. We can't genotype somebody in our clinic and say, oh, you've got the DRD4 7 repeat allele, you've got ADHD. We're talking about only a really small increase in risk, but collapsed across lots and lots of people, it suggests that's involved. Okay, so that's we are making progress in terms of molecular genetics, but we're nowhere near being able to use that information clinically. There are some consistently replicated environmental factors that are associated with ADHD. The most widely replicated is prenatal exposure, particularly to smoking and nicotine, but also to other drugs of abuse, maternal depression, negative parenting styles. So there is some contribution of that. But again, collectively, all of these environmental risk factors really only, if you think about that heritability graph I showed, all of these tied together, all the environmental risk factors are really only accounting for a little bit of the variance. So what was left from at the end of those bars up to 1, that's what's left for all of these things to sort of contribute to. So each of these by themselves is only contributing a little bit. One of the most recent kind of advances that we've seen, and this is a number of studies, well, I say number, 3 or 4 studies, but increasingly more are coming out, are looking at the interaction between genes and environment in predicting ADHD. And this seems to be a very promising area of work. So we know that any given gene is only conferring a little bit of risk for ADHD. But what happens when you take somebody who has this gene and link or cross it with or add on top of that some kind of environmental factor? And what we're finding is predicting ADHD with greater precision using these gene by environment kinds of approaches. So for example, there's evidence that individuals who have a particular variant of the DAT1, which is the dopamine transporter gene, who also have high levels of psychosocial adversity, and that's defined, it's a construct that involves sort of how much stress is in the environment, socioeconomic status, et cetera. It's an index. But if you have high levels of this adversity and you have this gene variant, you're at increased risk for ADHD compared to those people who only have the gene or who only have the psychosocial adversity. It's a double whammy, or it's the combination of both of them that seems to be driving the risk. There's also evidence that, it's on the next slide, evidence that in terms of going back, and I mentioned one of the more widely replicated findings is that moms who smoke during pregnancy, their offspring are more likely to have ADHD. A couple of recent studies have found that that risk is increased in kids who have a certain genotype. So if you have a particular gene variant and your mom smokes during pregnancy, you're at elevated risk for having ADHD compared to if you only have the gene or only if your mom smoked and you don't have the gene. So these gene by environment interactions we're probably going to see a lot more of those in terms of understanding exactly how those specific genes, which by themselves don't tell us a lot, it tells, number one, it allows us to understand the emergence of the disorder, but it also tells us maybe a little bit more about how those genes are working. So what is it about moms smoking during pregnancy, and based on what we know about what a particular gene does, what can that tell us about the neurobiology of the development of the disorder? So we'll see progress on that in the next few years. There are also, in addition to the genetics of the disorder, there is conclusive evidence that there are differences in brain function and structure in individuals with ADHD compared to those who don't. So using a range of neuroimaging techniques, these are findings looking at structural or anatomic imaging, so basically just looking at size and volume. Individuals with ADHD have smaller brain size overall. They have thinner cortex matter. They also have a number of different specific areas that seem to be smaller. Cerebellum, as well as some other places. So again, these are structural. This is not looking at activity, but just the size of the brain. We've also got lots and lots of studies showing that there are functional differences, so how the brain actually works. When we look at patterns of activation in certain parts of the brain, we see ADHD folks activating their brains in different ways. One of the interesting findings that seems to be falling out of the functional neuroimaging literature is that ADHD folks, oftentimes what you see if you look at these, not just that the non-ADHD people activate a certain area to perform a task and the ADHD people don't. What you're more likely to see is that the control people activate a certain area to complete a task. The ADHD people activate a whole bunch of other areas. So it's almost like their brains, just like what we see behaviorally, their brains aren't working as efficiently. So they get the job done, but they're not working as efficiently as those individuals who don't have the disorder. So that's kind of a gross way to think about things, but it's sort of replicated a number of times. So that's hopefully convinced or dispelled the myth that this is just this is just bad parenting or spirited kids. I mean, there is a huge amount of evidence to suggest this is a disorder that has genetic basis and is clearly neurobiological. I want to talk a little bit about adult ADHD and another myth. It's a childhood disorder and kids grow out of it. This is actually something that even in clinical and research communities, this is what was believed up until really the early 80s when we started to see more and more work being done on the persistence of ADHD. So what we see is actually that, and I mentioned this before, and you see it borne out if you look at prevalence estimates in different studies, somewhere between 50 and 60 is usually the number that it converges on, depending on which study you look at, of individuals who have it as a kid are going to continue to have problems into adulthood. And we're still not exactly sure of what it is, or we can't predict which people are going to persist. We're involved in a study now. There's some other studies looking at seeing whether genes are actually predictive of persistent ADHD. So maybe all the genetic studies that I talked about basically just look at ADHD at one point in time. One of the things we're doing now is to say, okay, let's look, if you diagnose ADHD now and then reassess a few years later, do the people who still have it compared to the people who now don't meet the criteria, are there differences in their genes? That's a plausible hypothesis here. I mentioned again, the overall prevalence in the population is around 4.4%. What's challenging, and this still plagues studies of prevalence of adult ADHD, is that our DSM criteria that I walked through at the very beginning, they were developed explicitly for kids between the ages of 6 and 12. So when we go to apply those same criteria, which are in the process of being modified to be more developmentally sensitive, we run into problems with adults. The best example, and what you have here are specific symptoms from the DSM on the left, and then sort of what we see or what the manifestation might look like in adulthood. But the most striking example that I always give is one of the symptoms on the hyperactive impulsive list is runs about or climbs on things excessively. Most adult patients that I see in the clinic can hold it together enough not to run down the aisles at the store and climb up on the shelves. Although getting patients referred from lots of rural areas, I've got stories of my adult patients who's, one guy was not terribly high functioning and was, I always ask this question when I have my adult patients about, I kind of frame it in terms of restlessness, because this is sort of how we think that this symptom kind of changes over time, that you sort of get socialized to be able to not run about and climb on things. So I always ask my adult patients, well, do you feel restless? Like you're keyed up, like you need to do something, but you don't know exactly what it is. And he wasn't really following what I was saying. And I said, well, as a kid, this symptom looks like running around and climbing on things. And he interrupted me to say, oh, I love to climb trees. And this is like a 32-year-old guy, so I can, I check that symptom as being present. But it's a challenge developmentally to be able to define these symptoms in an appropriate way to make a good diagnosis in adulthood. So if there's variability around how different people are defining the adult condition, that contributes to challenges in the research literature and being able to understand those prevalence rates. And that's why we might see wide estimates of what the rates of persistence actually are. In fact, there was one study showing that I said about 50 to 60% of kids, and this is sort of what the best are, persist into adulthood. One study was conducted where they followed the letter of the DSM to a T. There was no additional interpretation like changing these symptoms like I just explained. And they found when you adhere very, very, very strictly to the criteria, 2% of individuals persisted. So there's a wide range there. I don't believe that study, but there's clearly some challenges there. Talked a little bit about this. We went through, and I did talk about all of the different problems that this can lead to in terms of increased risk for incarceration, getting STDs, being divorced, being unemployed. One of the things that, again, to kind of go back to the clinical side of things, that I see a lot is individuals who have not achieved in their jobs nearly what they should based on my estimation of their functioning, and usually they know that, and then that contributes to their own sort of dysphoria or being down on themselves. So I saw one guy who we do an IQ screener for a lot of our studies. This guy was being screened for one of our studies, and his IQ estimate was like 130 or 140, which is really high. He had just lost his job stocking shelves at Walmart. He was a good guy. He was extremely articulate and had kids and was, beating himself up about the example he was setting for his kids. And he had just, he just couldn't, for a variety of reasons, specifically related to his ADHD symptoms, couldn't hold down a job. Now, a lot of other examples that are a little bit more subtle in terms of people who get very, very frustrated because they know that they're smarter than their boss or their boss's boss, and they know that. And I believe them. But because of all the other things that are involved in their job and how the ADHD symptoms impact that, they just can't get to that next level. So I've talked now about sort of what we know about its persistence, what we know about it being a genetically driven disorder. Talk a little bit now about assessment and treatment. So the myths, and they're first of all, one that is probably the most frustrating to me, has to do with assessment. And the myth is that you can diagnose ADHD with a brain scan for the low price of $2,500. There are a number of different places, and again, this is the kind of thing you find when you do a Google search of ADHD that say, we can conclusively tell you whether you have ADHD or not in 15 minutes with this SPECT scan, and it's $2,500. Or come in, we'll put some electrodes on your head, and we'll be able to evaluate your ADHD. And there's a lot of people that follow up on that, and again, that contributes to public perception about misdiagnosis. Those people may, who knows whether or not they get a diagnosis, but clearly it hasn't been a good thorough evaluation. And if you think about the criteria that I went through, how is a computer test or an imaging test going to get at all of those criteria? How is it going to be able to conclusively say, these symptoms might be caused by anxiety or depression or substance use? How is it going to be able to say, this is really affecting your social relationships in the following ways? You just can't get at that. We're nowhere near being able to diagnose it with genetic tests, in spite of all the evidence that I showed you in terms of our understanding of the imaging literature. Again, those are studies that just are highlighting differences between groups. They're not nearly strong enough, or the differences aren't stark enough to be able to use them clinically. So it's really important to emphasize that you cannot diagnose ADHD in any kind of quick and dirty way. That's a challenge for a variety of reasons. There's all sorts of myths circulating about the treatment. One of them is that treating with Ritalin or other kinds of stimulant drugs leads to addiction. There's actually a lot of work that's been done in this area. Some of it's fairly controversial, and what seems to be the most, the best, most well-informed answer to that question now is treatment with stimulants when kids are little really doesn't have an impact, good or bad, on the development of substance use problems later on, with the possible exception, and this is where the jury is still out, possible exception of smoking. There's a lot of controversy suggesting that maybe treatment with stimulants has some impact on the development of smoking or nicotine dependence. We still need a lot more work in that area. But again, it is a myth to suggest that it definitely leads to addiction. So I want to talk just for a couple of minutes about assessment and treatment, and then we should have time for a few more questions at the end. I kind of hopefully made this point already, and this slide is just to remind me to talk about what we really need to rely on to make a clinical diagnosis. And this is this should be in order from bottom to top of importance. The most important thing in order to make a good diagnosis is the interview and history. We've just got to talk to the patient or talk to the patient's family or parents to get that information to address some of those criteria that I talked about. Standardized assessment measures are also important. And the reason they're important is as follows. That first criterion for the symptoms. Remember, one of the very first things that I mentioned was that there is some subjective clinical impression to be able to define a symptom as being present or not. By sort of thinking about how that is related to typical development. We have rating scales that have been developed that have these symptoms, that have big normative samples that they've been developed with. So in other words, you can give it to a patient, you look at the scores on this and say, oh, well, compared to a group of 4,000 third grade boys, this person is scoring 2 standard deviations above the mean for this particular behavior. You can get some level of confidence that, yeah, that's developmentally inappropriate. And we've also got the same kind of rating scales for adults. So we do rely on these standardized assessment instruments to get a sense of the developmental appropriateness of symptoms, or the developmental, how deviant they might be from a developmental perspective.
Would you mind mentioning a couple of the names of some of those standardized assessments?
Sure. The ones that we use, and there's a number of them out there, the ones we use are the Connors rating scales, Connors parent and Connors teacher rating scales. We use them because Keith Connors started our clinic 20 years ago, retired a few years ago, and also the Connors adult ADHD rating scales. They probably have the most extensive normative database. So the samples that they were developed on are bigger than other rating scales. But there's other ones out there. There's one called the Vanderbilt, which is nice, and it's available for free. You have to buy the Connors scales. But the Vanderbilt scales you can get from a couple of different websites. The American Academy of Pediatrics is one of them. The disadvantage to that is it doesn't have as good of normative data as the Connors and other kinds of rating scales. I can give you more after we finish up as well. Observation can be important, but it's not critical. Oftentimes I'll have a parent, they bring their kid in, and they're horrified because their child is behaving well. Say, I promise this is not how they really are, and I say, I believe you, because most kids can hold it together in a novel situation, for a one-shot deal. So that's why we sort of now on the flip side, the kid that comes in and runs up and down the hall and bursts into my colleagues' offices and jumps up on their lap, we can get some clinical data from that. Physical examination, we don't really rely on. I'm a psychologist. The rest of us are psychologists. We will refer to one of our consulting psychiatrists if we have concerns about medical issues that might be going on. If there's concerns about, for example, a thyroid problem, or some kind of, if they've in the past had some kind of head injury or something like that we think might be contributing, then we're going to refer. But in terms of routine practice, physical examination is not necessary. I've got like 1 minute in order to leave us a few time for questions to talk about ADHD treatment. Tiny little area, but let me try to summarize. There are a wide range of approaches that have been taken for treating ADHD, most of which have zero evidence that they work. This is some of them: cognitive therapy, individual sort of traditional psychotherapy, biofeedback. Neurofeedback is a hot topic now. There are some studies that are showing promising results, but there are some problems with those studies that they haven't quite achieved what I would consider to be an evidence-based, to meet an evidence-based criterion for treating ADHD. Food, vitamin, mineral treatments, none of these have been shown to work. I will say that I've had a number of parents that come in, they say, I did this, that, or the other with my child's diet, and I noticed a huge difference. Well, I'm not going to say, well, no, you're lying to me, because our studies say that that's not true. There's variability in those studies, and it's certainly possible that there are idiosyncratic responses to different kinds of things that kids put in their bodies, that if you change that, you're going to change behavior. But in aggregate, and as a clinician who's relying on the literature, I can't recommend to a parent, based on what I know about the literature, that for any given kid that's also going to work. So there's some recent work actually that's somewhat promising with omega-3 fatty acids, as well as a couple of other supplements that seem to maybe have some promise, but again, those are fairly few and far between. In general, there are two approaches to treating ADHD that have evidence-based. There's medication. Medication's divided into, and I think I'm looking around, it looks like everybody's got copies of the slides, so you can look through, because the rest of the stuff I was going to talk about treatment is fairly general, and you can get a sense of that. If you have questions, you can ask me or shoot me an email. But in general, there's two classes of medication. There's the stimulants, which have been studied the most and are the most efficacious, and there's the most products. There's two types of stimulants. There's amphetamine and there's methylphenidate, and there's 4 or 5 different products. that have as their main ingredient each of those two. And then there is one non-stimulant that is approved for ADHD. It's called, the brand name is Strattera. It's atomoxetine. There's a couple of other promising agents that are in development. One, probably the closest to being out there and available will be called Intuniv, and it is guanfacine. It's an extended release formulation of guanfacine, which has traditionally been used to treat hypertension. That'll probably be out by the end of this year, and then there's a few other compounds that are sort of lined up behind that that'll probably be coming out in the next few years. So I'm going to actually stop there to make sure, because we go to 120. Is that what? Okay. Oh. Well, I'm rushing through. Well, it'll be more fun to answer questions anyway, because like I said, most of the stuff on these specific agents, you can take a look through, or maybe some of the specific questions you might have about treatment will come up. I need to mention, especially as a psychologist, that the other evidence-based approach to treatment that we have is psychosocial or behavioral interventions. And that takes on a few different forms, but the main components of a good psychosocial intervention for ADHD involves working with the parents and teaching them strategies for managing behavior. Most of the strategies are things that are fairly intuitive, but need to be modified or sort of fine-tuned in order to work effectively with ADHD. And then also working with the school, usually doing some sort of contingency management program where you identify problems in the classroom, you monitor those on a regular basis, and then you get home, you send feedback home with the kid about how they did for their target behavior, and then they get consequences at home, good consequences, if they meet a target. So we call this a daily report card, and what they're being graded on is how many times they get up out of their seat, or how many times they interrupt the teacher when they're talking, or something like that. So that's actually one of the most simple, straightforward, and effective, sort of the most bang for your buck behavioral intervention that we can implement for ADHD. So one other thing that I'll say also is that one area that is very another hot area is developing non-pharmacological treatments, i.e. psychosocial treatments for adults. It's a very new area, and again, owing to the fact that it's only been in the last 10 or 15 years that we've really started to understand and acknowledge the persistence of the disorder. But there is, in my mind, more reason to come up with good non-pharmacological treatments for adults than there are for kids. Primarily because with adults, they have a lifetime of habits and skill deficits that they have acquired. And so medication is going to work for the symptoms in the very short term, but it's not going to undo all of these other kind of problems or patterns of behavior that they've developed over the years. One quick anecdote, and then I promise I will stop. We've been piloting some psychosocial treatments for adults. And we put together a number of modules before our first, we wanted to do this as a group. We put together a number of modules. We were trying to be pretty sophisticated. We had stuff in there about communicating with your spouse and other interpersonal things that we know are problems with ADHD. And we recruited a small group of really, really high-functioning patients because we wanted to get good feedback from them to sort of fine-tune this. And so this was, physicians and lawyers and very, very bright people, very high functioning, that were able to tell us what they liked, what they didn't like. We got to the end of the treatment and we asked them, what did you like best? How about these fancy interpersonal things we put together? And they said, well, that was okay, but what I really, really liked was learning how to put the different color stickers on the manila folders in my office. That was the greatest thing ever. And it occurred to us that, again, these are people that, in spite of how high functioning and how far they might have gone, have some fundamental skill deficits that need to be addressed. And when you address them, it just seems like the light is shining down and a whole new world is opening up for them. So that's the emphasis that we place on non-pharmacological approaches to treatment for adults. So let me stop there and open it up, I guess, for 15 minutes or so to talk about other questions you all might have. Yes?
My question is, first of all, do you think there's such a thing as a diagnosis of ADD and not ADHD? So we have attention deficit. My other question is, do you think that we see it more as we've moved from an agrarian society where you could run around, jump around, and cut hay, and now we're asking people to sit for much longer in classrooms?
Yep. So to answer the first question, that's an easier answer. The ADD, ADHD distinction it's all nomenclature. And if you look closely on that arrow on like the 5th or 6th slide on the timeline, in 1994 with our last version of DSM, we changed the name of the disorder to ADHD, and there are 3 subtypes of ADHD. There's inattentive type, which means you've only got the inattentive symptoms, you don't really have the hyperactive impulsive symptoms. That's what used to be called ADD. Then you've got hyperactive impulsive type, which is only the hyperactive impulsive symptoms, and then you've got combined type. So there is ADD, it's just now called ADHD inattentive, but it's you tell a parent, your child has no hyperactive impulsive symptoms, but they have attention deficit hyperactivity disorder. And they go, huh? But it's inattentive type. So it's a nomenclature thing. The second question, in terms of seeing the emergence of this, it's absolutely possible. I mean, certainly over time, and the shift from an agrarian to a technological society is associated with that. Another thing, and this is a trend that's even more evident in the past 20 to 30 years, is the decrease in just physical activity that kids get in schools. And so people have wondered, is this, might this be associated with increases in prevalence? Well, the problem is, at least for the latter argument, is that we haven't seen much of an increase in prevalence in the last 40 to 50 years. Beyond that, in the last 100 to 200 years, that that would address sort of a bigger shift. Although I guess argument against that, although most of the countries that have been involved in those prevalence studies across the world are developed countries, but there's it might be interesting to go in there and look and sort of sort out based on what the primary rural versus urban kind of things. Again, I think that probably contributes to the referral rates and problems, but given the evidence that it's a genetic disorder, I don't think, it's out there. And that kind of goes back to what I was saying before, is that there's, some, sort of evolutionary biologists teaming up with geneticists and psychiatrists and psychologists to think about what is it about this disorder that might have been adaptive, 1,000 years ago, and why have these genes persisted? So it's a good question. I don't have a conclusive answer for you. Yes.
So, with it being a genetic disorder, and assuming that that there can be some impact on genes from the environment, I'm wondering what the research shows about things like vaccines, pesticides, food additives, preservatives, all those kinds of things that, 100 years ago we weren't really having to deal with, our bodies weren't having to deal with.
Yep, it's a great question. It's there's very little work that's been done. Work is just now. I mean, there are probably what I know of, half a dozen studies that are looking at a whole different range of that, sort of post, epigenetic types of approaches to understanding ADHD, as well as other psychiatric disorders. But at this point, we just don't know. There is some evidence that, at least in animal models, and I'm not sure if there are any clinical data, at least in animal models, exposure to PCBs or to other pesticides in animals certainly results in emergence of behaviors that we sort of think of as associated with ADHD. So I think that there's probably, and there's also evidence that lead exposure in kids increases the prevalence of ADHD. But again, there we're talking more again about pure environmental effects. And your question has, might there be interactions or might there be epigenetic effects that sort of actually change gene expression, once you get exposed to those things?
I'm just suspicious that a lot of what we see now, increase in autism, ADHD, asthma, food allergies, all that kind of stuff, is genetic predisposition and environmental triggers, a whole slew of them, because our environment is so much more toxic than it was 100 years ago.
Yep. No, it's plausible, and we need more work to figure that out. Yep. Thank you.
I just wanted to actually respond to what you were saying, though, Alice, and go back again to what Scott was saying, and that is really what we might be seeing, with your, vaccines and whatever, is more recognition of what the disorders are, and more of a refinement, in diagnosis. Not that those can't be factors, but I think we need to be careful, when we look at sort of, what's the history, and is it because our environment has changed? I think we need to be really careful about kind of the broad, speculation around there.
Well, yeah, but I think it's no, your point's very well taken, and certainly, making sure that we're defining and identifying kids and adults with ADHD in a thorough and comprehensive way is very important, and that contributes to sort of this public perception that it's overdiagnosed. But it's plausible certainly to speculate about how, I mean, and that's a kind of question that we know nothing about, because we haven't yet done the studies, and there are initiatives underway to start to get it. Because to answer that kind of question conclusively, you've really got to take a population-based approach to studying things. So you have to take something like this National Children's Study that's just getting underway, which is, I can't remember, $100 million from the federal government to identify like 500,000 women, and then follow them with the goal of identifying preconception 100,000 kids before they're even conceived, following them during pregnancy, and then following them through their life. I mean, and that's the kind of sample that we need to get at to understand, okay, and they're sort of all over the country to figure out, all right, are there environmental effects directly or interacting with genetic effect or genes and so forth. Yeah, but much, much bigger. Yep.
Is it on? There it goes.
That's right.
So I have two questions, really. One is more specific, and then the other is kind of a broad, give me information. Related to the stimulants and the medications that are available, I mean, obviously, the common side effects right off the top, sleep and appetite. Mm-hmm. Are there things that are on the market now that are, I guess, less intrusive or that have less of that effect? As a parent trying to manage a fourth grader who doesn't go to bed at night, doesn't eat during the day, I mean, what else is out there for us? And my next question, very broad, is just resources. So I can't go out and Google ADHD. I don't want to read Wikipedia. What's out there for us as parents and as professionals that are dealing with this?
Right. So to answer the first question, I mean, it's very, almost all the stimulants are going to have those side effects. The first recommendation would always be to consult with the prescriber and make sure it's not a dose issue. Oftentimes, in some kids, if these medications are managed properly, the response rate is very, very high in terms of being able to effectively treat ADHD. But some kids more than others, that window of benefit is much smaller. In other words, the sweet spot of the dose that you get before you start to see those prohibitive side effects. And so, some kids might be more sensitive. Sometimes it's just a matter of not trying the right dose or sculpting the dose as the prescribers like to talk about. So that's the first recommendation. I mean, the non-stimulant that's out there doesn't have those side effects of appetite and sleep problems, but it's got its own side effect. Its side effects are sleepiness and nausea a lot of times. So we get a lot of kids with upset stomach. My clinical experience, and actually in terms of efficacy, all of the stimulants work the same. You can get your drug company reps that would argue and try to provide information, but there's no study that suggests that one has superiority over the other. That's not quite the case with atomoxetine, with Strattera. The effect sizes or the relative efficacy is lower than the stimulants, but it still works well. In clinical experience, less my direct experience other than talking to parents because I don't prescribe, but talking with my psychiatrist colleagues, is that Strattera works really well or it doesn't really work at all. So it's not, with stimulants you can get a pretty good response or a great response. Usually you're not going to get no response. Strattera seems to be like, yes, it's great, or this doesn't work at all. So that's the specific question. The general question, you give me a chance to plug our clinic and our program, because I say that halfway tongue-in-cheek, but send me an email. We have the kind of Collins-approved list of websites that we give our families. We actually have resource packets that have websites, books, some general information from some of the websites, and we really try to set ourselves up as the central place to get resources. We also have about every other month, or either quarterly or every other month, we do a free parent seminar or free seminars for not just parents but anybody who's interested in ADHD. The topics vary. I think our next one's coming up next month, and I think it's going to be on medication, actually. And Alan Chrisman, who is our medical director for the clinic, is going to be speaking there. So shoot me an email. You can look at our website, too, if you just, it's a long address, but if you Google, if you Google Duke ADHD, our program should be your first hit. So, yeah.
The question I have is, you talked about... You need the mic.
Is it on? The question I have is, because it's so highly genetic, as you become an adult, say these children have been identified and they've been being treated with medication, then at what point, as they go on to adults, if it's genetic, should they not need this medication all along? Or when do you determine, pull them off and see if it's prevalent? I mean, what's the standard there? What's the recommendation?
That's a great question. What's interesting is that in spite of the strong genetic basis, there's still 40 to 50% of people that don't continue to have problems. Now, those people may still be somewhat symptomatic, but for whatever reason, they've learned to overcome they've learned compensatory skills, et cetera, et cetera. But in terms of clinical practice, what we recommend, and it's a question that comes up fairly frequently, is that we recommend at least every usually about once a year, especially once they get to be, try to do a trial, work with your physician to lower the dose or pull them off the meds and see what happens. Usually don't do that around final exam time or something like that, but just to get a sense of the continued need for that. And then we also recommend every 2 to 3 years, and that interval can sort of broaden out as they get a little bit older, to just do a reevaluation, to get new parent input, new teacher input, come to a place like ours or another psychologist, just to say, is ADHD still really the primary presenting problem, and what's the continued need for treatment? So on a more frequent basis, sort of a retrial of meds, and on a slightly less frequent basis, a full workup just to see the continued need, and to identify other kinds of areas of impairment that may pop up. What we typically might see, we might see a 16-year-old who was diagnosed when they were 7, and they've been treated that whole time, and lo and behold, the ADHD has remitted, but now they're depressed. And so, that's what you're going to be able to pick up in you might not pick that up by just doing a med trial and stopping them and say, oh, well, their ADHD symptoms don't change. Well, that's because they're not there to begin with anymore. But now they've got, some other mood issues or something like that. All right? No more questions? All right, well, thank you guys. This was fun. I appreciate it.